significance of each of DW's laboratory findings. The first one is being positive for ANA or anti-nuclear antibody. This is an antibody against the nucleus of the cell and can indicate the presence of autoimmune disorder. The second one is being positive for double-stranded DNA antibodies. This antibody is an antibody that attacks against the DNA of the cells and is a subtype of ANA actually, and is also very highly specific to SLE. The third one is being positive for anti-smooth muscle test, which is to detect the presence of certain antibodies against the smooth muscle cells, and this can also indicate an autoimmune disorder against the smooth muscles. So the fourth one is elevation in both C-reactive protein and erythrocyte sedimentation rate. So this can indicate the presence of inflammation in the body. The fifth one is elevation in both serum C3 and C4, which can also indicate for the presence of inflammation and also indicate the presence of autoimmune disorder. So the last one is joint swelling. This can be a very common symptom of arthritis, but it's also a very common symptom for SLE. Given that most tests are non-specific, how is SLE diagnosed? So far DW has been positive for ANA, double-stranded DNA antibodies and anti-smooth muscle test. And she's also having elevation in both her C-reactive protein and erythrocyte sedimentation rate, and also an increase in both C3 and C4 serum complements. So these tests alone do not indicate for SLE, but since they are performed on the same individual, so this can highly indicate for the presence of SLE. Plus, DW also shows non-specific signs for SLE such as fatigue, weight loss, and also fever. DW also possess some very specific criteria for SLE, which includes scaly rash across her nose, cheeks, back, and chest, which would otherwise be known as the famous mala rash or butterfly rash. And she also has joint swelling. The combination of all of these symptoms, signs, and laboratory tests are what qualify DW to be diagnosed with SLE. So what priority problems were addressed in DW's care plan at the time of diagnosis? So the first one is coping and understanding of the diagnosis and disease itself. The second one is monitoring of pain level and her body temperature since she has swelling and fever. The third one is medication administration and how the medication works, which she was administered with hydrochloroquine and deltazone. And the last one is ways to continue living a normal life despite having SLE, because there is no cure for this disease. So the symptoms can be controlled with the right care plan.
Based on the lab test result, it can be concluded that the patient has problem with kidney probable of damage. First is sodium level. It indicates normovolemic conditions that can either signs of renal failure, adrenal insufficiency, and syndrome of inappropriate ADH secretion. Second is chloride level. It may indicate electrolyte imbalance that due to kidney problems, so its function to control the chloride metabolism. Next is total carbon dioxide. The result indicate that the patient might have Addison disease, shock, or kidney disorder. Bind or blood urea nitrogen level may indicate kidney not working well or dehydration cases. Next, creatinine level. It may indicate kidney diseases or an increase in consumption of protein. Protein present in the urine indicate there is problem in the kidney, while red blood cell may indicate kidney damage or infection. First is hydroxychloroquine. It will help improve outcome with lupus nephritis and also reducing lupus-related flares and disease damage occur. Second is corticosteroid therapy and immunosuppressive agent. It will help control more lupus activity over major organ, and if corticosteroid is not suitable, immunosuppressive agent might help. Next is avoid drugs that affect renal function. This includes NSAID, especially in patients with high creatinine level. Fourth is avoid pregnancy. It is because it may worsen the renal disease and some treatment are teratogenic. Fifth, alter diet based on condition of patient. Based on this patient condition, restrict protein intake if renal is significantly impaired. And lastly, limit the time spent in the sun and in fluorescent and halogen light. It will help to avoid triggering the lupus flares in the patient. This is calculated by using Monstella body surface area formula. It is indicated that the patient have to have 169 mg for each dosage. So for each dose, it is needed 84.5 mg.
Based on the case progress, the other finding indicative of TNF involvement from SLE. First point is seizure slope decrease, difficulty expressing their talk because the inflammation and antibody created by lupus aggravate the central nervous system and brain. Next, decreased level of consciousness indicate the deficit in brain function. When a brain receives insufficient oxygen in hypoxia or insufficient blood in shock. Next, muscle tone, cause of inflammation in the muscle usually in the hip, thigh, shoulder and upper arm. It leads to difficulty to stand up or raise arm. Then polar, which tend to purple equal round reactive to light accumulation. In this test, results show the abnormal result reaction to light to object distance and condition of the eyes like size and shape. The preventive measure need to protect DW at this time is full resuscitation equipment for the case of the cardiac dysfunction or oxygen deprivation such as cardiorespiratory monitor, bed valve mask that supply readily available oxygen, and seizure pack which prevent the person from injuring themselves against the metal bar of the hospital bed. Next, infection control divided by two groups which are standard precaution and severe treatment. In the standard precaution, the bed precaution is very important which need to be placed close to ground to minimize the patient fall. Next, having a plastic shower chair during shower which to minimize danger of drowning. In the seizure treatment, there are few medications used to counter the infection like anti-malaria, anti-epilepsy and NSAID. Next, monitored by electroencephalogram test (EEG), which can detect the wave pattern of brain. It also used to determine the causes of seizure, which indicate involvement of CNS. Then EEG may reveal a pattern whether a seizure is likely to occur again or not.
It is needed to constantly check her blood pressure. Hypertension is more common in SLE patients than in the general population, and hypertension increases the CVD risk in SLE patients. SLE patients have a 5 to 6-fold increase in the risk of a cardiovascular event and a 50-fold greater risk of kidney failure, stroke, heart failure, and acute myocardial infarction. Renal disease, which occurs in the natural evolution of some systemic autoimmune diseases, may also result in the secondary arterial hypertension. Glucocorticoids and non-steroidal anti-inflammatory drugs, which are used infrequently with patients with various autoimmune diseases, including lupus, occasionally contribute to the resistant forms of hypertension. Next, it is important to assist her with proper hygiene practices. SLE patients are more vulnerable to carrying infection due to their reduced immunity. Proper hygienic practices are important in preventing nosocomial infection. A clean hand will reduce the incidence of healthcare-associated infection transmission. For example, by practicing safe hand washing techniques and hygiene practices in relation to their surrounding and daily routine. Lastly, always empty her urine collection device and measure the urine output. A high protein or red blood cells concentration in the urine means kidney damage. SLE can affect every other organ system in the body, and lower urinary tract diseases have been known to be one of the rare complications of SLE. Lupus cystitis, neurogenic dysfunction secondary towards transverse myelopathy, cyclophosphamide administration, inflammatory polyneuropathy, and infections are known to be related towards bladder dysfunction in patients with SLE. Urine output is often used as the marker of acute kidney injury, and it can show various signs of inflammation in the kidney, such as red blood cells clumps or the presence of excessive amounts of proteins. A decreased urine output is linked with acute kidney injury. First is the increased risk of infection. SLE patients appear to carry an increased risk of infection. Careful monitoring of infectious complications is warranted among SLE patients receiving immunosuppressive therapies, in particular those on high-dose glucocorticoids and cytotoxic drugs. In terms of extrinsic risk factors for infection, the use of dose-dependent steroids and cyclophosphamide has the strongest effect in suppressing the immune responses against microorganisms.
nexus leukopenia, careful monitoring of the complete blood cell count and dosage adjustment according to white blood cell count is usually adequate to prevent serious leukopenia. Immunosuppressive drugs inhibit the activity of the immune system by reducing the proliferation and function of cells associated with immune reactions. The therapy downregulate NOD2 expression in CD8+, T cells, monocytes, and dendritic cells, hence resulting in low white blood cell count. Lastly is hyperglycemia. Another side effect of immunosuppressive medication is hyperglycemia and secondary diabetes, as they may alter the way the body manages the glucose. It is important to routinely check her blood sugar level to establish an effective medication regimen in order to maintain a stable blood sugar level that is close towards normal level. Aerobic exercise such as walking for 30 minutes every day can help to lower the blood sugar level and possibly decrease the medication's requirements.
Plasmapheresis is a non-surgical therapy that can be used to treat a variety of autoimmune diseases, including SLE disease. So, due to the disease that DW experienced, this plasmapheresis removes the antibodies against her own body cell and tissues from the blood. Autoantibodies are proteins that found in the plasma. They mistakenly attack the body's own tissues. In some cases, this procedure is also used to remove the toxin or metabolic substance from the blood. This plasmapheresis involves removing blood through a needle or catheter and secreting it through a machine where the blood is separated into red cell, white cell, platelets, and plasma. The plasma, which is the fluid content of the blood, is discarded and replaced with a fluid that mainly albumin solution. The substitute of the plasma and the patient's own blood cell, which is red cell, white cell, and platelets, are returned to the patient through a return needles. A plasma exchange takes about 2 to 3 hours, depending on the amount of plasma that needs to be removed. The process is very similar to dialysis. The plasma can be removed from the body to cleanse it to treat various types of disorder. This plasmapheresis helps her feel better because a plasma exchange may prevent the body from producing more harmful antibodies. In the question number 12, DW is complaining that she feels a headache and some dizziness. Side effect of headache and dizziness after plasmapheresis therapy is very common. So, from the vital sign above, we suspect DW has low blood pressure. Plasmapheresis can lead to hypotension, which is a reduction of blood pressure. This occurs usually due to decrease of plasma volume. When the blood pressure drops, heart rate is also increased and the blood vessel in other part of the body constrict to help maintain the blood pressure. In order to treat this hypotension, DW need to drink more water. This is because fluids increase blood volume and help to prevent dehydration.
Over the next 2 to 3 hours, the care that should be given to the patient is stabilizing her blood pressure to ensure that the blood pressure does not drop to a flatter range due to hypotension. Next, decrease her headache and dizziness, which may be caused by plasmapheresis side effects. One of the side effects of methylprednisol is slightly reducing the body immune system, which in turn lead to increase in body temperature. Thus, we also should ensure that her body temperature stabilizes. Plasmapheresis can result in dehydration and hypotension. Thus, to reduce the risk, the patient is advised to drink 6 to 8 glasses of water. In addition, we should also assessing any neurological and vital signs to ensure that we are aware of any complications. To ensure that the patient's condition has stabilized, the outcome that can support this are: firstly, decrease in inflammation. Inflammation is known to commonly occur in SLE patients. The treatment with IV methylprednisol, which has the ability of anti-inflammatory and immunosuppressive actions, aid in the decreases of inflammation. Next is decrease in fatigue. One of the common signs of patients with SLE is fatigue. Thus, the improvement of patient's energy is a sign that the condition has stabilized. SLE is an autoimmune disease where the immune system attacks its own body. The improvement of immunity of the patient signals the improvement in patient's health. In addition to that, patient with condition has stabilized also demonstrates stable vital signs.
My name is Arina. So there are 5 topics that DW must be taught before she is discharged. First is in terms of medication regimen. If DW has acute flash, she could take hydroxychloroquine or NSAID. If chronic lupus arthritis, she could take methotrexate. For moderate severity, she could take azathioprine or mycophenolate. However, she could avoid taking antibiotics containing sulfamethoxazole and trimethoprim. This is because it could increase insulin sensitivity and lower blood counts in people with lupus, resulting in lupus flares. Next, when does DW need to notify healthcare provider? When she had experienced severe abdominal pain or any chest pain, excess bruising or bleeding or any confusion or mood changes. The third thing is about coping. She could join a support group or maybe try to reduce stress by setting a realistic goals, and then she could also get enough rest and sleep and try to take medication as directed. Fourth is for proper hygiene. She is advised to wash her hand regularly and also treat any cuts promptly, and then avoid any contact with anyone who has infection, and also do not use any items that can harbor germ. Lastly is self-care with SLE and kidney complication. She must avoid too much of sun exposure, such as wearing long sleeve shirt, and then eat healthy food like reducing sodium intake, and then also exercise regularly. So next question is about DW husband that did not allow DW to go work because he's scared that the lupus will weaken his body and thus killing her. So how our response should be? So first, we must inform the husband that he should support and encourage DW in her career if she would take proper precautions in workplace. Second, inform him that he could suggest DW to take a flexible working hours, job sharing and telecommuting to help her keep up with her job. Third, he should also be informed that working would not threaten DW life if she could adjust her schedule, such as taking longer hour breaks to avoid over fatigue. And then he should also be given experiences of other SLE patients who are able to cope with their condition and can manage work.